Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. This activity is supported by an independent educational grant from Regeneron Pharmaceuticals, Inc.
Welcome to the Retina Futures Forum focused on wet AMD. I'm Layla Bizuch, a vitreoretinal surgeon in Durham, North Carolina, focusing both on adult and pediatric retina, including surgical and advanced therapies. I'm really looking forward to this discussion, and I'm especially glad to be joined by my amazing colleague and friend, Diana Doe, who brings just tremendous expertise and experience in this space. Diana, I'll turn it over to you for introduction.
Hi, Layla. It's always a pleasure to have a great conversation with you to discuss the most pressing issues in retina. I practice at the Byers Eye Institute at Stanford University, where I'm professor of ophthalmology and vice chair of clinical affairs. Thanks for inviting me, Layla.
Thank you. It's a pleasure to be here with you. Now, let's start off kind of just a big picture type of thing with it's, as retina specialists, we are really excited about all the innovation in our field. We're often leading those innovations and bringing some innovating therapies to our field. But I think one of the challenges that we face today isn't the lack of innovations, how quickly we potentially adopt those new therapies and techniques in our field. And we often rely on what's tried and true, but sometimes these habits, I feel like, slow us down most certainly. So let's start kind of discussion by asking ourselves, where in your own practice has a familiar approach become a barrier to something better? And building on that, if innovation is moving quickly, our goal is often to keep up, but sometimes we're just not as fast in clinic. And I'll often say my patient is doing stable, for example, but stability may not mean at that moment the most optimized. I think the optimization is truly different. It may mean sustained control, for example, in our world, minimal fluctuations in terms of fluid or visual acuity, and really, truly lowest possible treatment burden. So the real question is really, do we stop at stability or do we really push the boundaries to reach that optimization? What do you think, Tana?
You bring up an excellent point, Layla, and I think the disease that I take care of a lot is neovascular age-related macular degeneration, much like your clinical practice, and that's where we see these chronic patients who are being treated with intravitreal anti-VEGF therapies. And I know we think that we're taking excellent care of our patients, but when our colleagues discuss real-world data outcomes, it's surprising that our patients aren't achieving the most optimal visual acuity outcomes. And the biggest barrier is undertreatment. And I think that's because we're not giving our patients the best, most innovative medicines that we can that have potentially greater durability. What do you think, Layla?
Yeah, no, I couldn't agree with you more. We fall into these, what we call comfort zones. And most certainly I'm comfortable with continuing the status quo and giving my patient continuous injections and preserving their vision. But I think we definitely in this day and age with amazing new therapies on the market, we should be asking ourselves more, is this patient truly not just stable, but optimized? Is it okay to kind of continue status quo, or should we think about new therapies and giving and extending potentially treatment for that patient further? So in that mode of transitioning to newer therapies, what is some of the evidence out there that would help us think about that sooner or transition sooner?
I think one of the challenges is that many retina specialists were comfortable using the first generation anti VEGF therapies, such as aflibercept 2 milligrams, because they're very efficacious and safe. But when we look at the new data from faricimab, which is the first bispecific drug that was developed for retina because it inhibits both VEGF and angiopoietin 2, or we look at aflibercept 8 milligrams, which provides 4 times the molar dose of aflibercept 2 milligrams, the data from the phase 3 clinical trials is very impactful. It tells us these medicines can be delivered safely and provide efficacy with extended durability. In the clinical trials, Layla, those patients that were randomized to faricimab or aflibercept 8 milligrams could be dosed every 12 or 16 weeks, yet still have non inferior visual acuity outcomes compared to aflibercept 2 milligrams. And these results were consistent for 1 year of follow up or 2 years of follow up or beyond. Did those results resonate with you and change your clinical practice?
I would completely agree. Those are really impressive results and interesting for certain. And we as specialists keep on saying we need longer duration therapies. The PAT survey, ISRS PAT survey, over and over brings that up as number one really need in our community is durable options. And yet we now have longer duration therapies and we can extend our patients to 12, 16-week interval, which I think is really a great options to maintain that stability in vision as well as drying effect on OCT. So really with this amazing evidence we have from clinical trials, how do you really define success, so to speak, in care of your patients? What does the success in patient care look for you?
I think the interesting dilemma here is in clinical practice. Usually, my definitions of success is eliminating the fluid I see on optical coherence tomography because OCT imaging is the go to way to evaluate neovascular AMD disease activity. And so I'm looking for absence of both intraretinal fluid and subretinal fluid. What about you, Layla?
Yeah, exactly the same. I feel like we rely very heavily on OCT technology to help us look for that drying effect of the agent. And we solely often rely on that. I definitely take a peek at that visual acuity and I want to make sure it's maintained. But I feel like I really make my decisions on OCT. So similarly, I want to see really drying effect, complete drying effect to make me feel comfortable towards the extension and introducing potentially even new therapies.
I think that brings up an interesting point because when we looked at these pivotal clinical trials, obviously, when they had made the trial design, their retreatment criteria is different than what we use as clinicians every day in clinical practice. In many of these clinical trials, they had a certain threshold before the patient could be dosed more frequently. For example, they could tolerate fluid on OCT, and only if it was like above 50 or 75 microns could retreatment be administered. What do you feel about that fact? Because some clinicians would say that's not how I practiced in the real world, but yet in the clinical trials, the vision still was outstanding in the end.
Yeah. No, I do see a paradigm shifting or a practice shift in the future as not just these clinical trials, but others that are currently ongoing are teaching us and helping us understand that some fluid is okay. Um, but with that said, I think we all of us struggle still in clinic to accept that fluid on that OCT and want to really have true drying effect. And why is that the case? Because we're always concerned, what if that patient doesn't make it to the next visit with us? What if they miss and now that fluid may be, increased and help them potentially with some visual acuity changes? Where in clinical trial setting, we know those patients are going to be reminded and brought in for regular visits. So I feel it's definitely, while we learn from clinical trials, it's not fully applicable in the real world. And we most certainly, and foremost want to treat our patients and make sure they continue with their visual acuity. So with all of the discussion, let's dive into case examples. Let's kind of see how both of us take care of the patients currently with the new therapies available on the market. So starting with our first patient, this is a 72-year-old female. Miss Williams comes in with a new diagnosis of wet AMD. Her affected eye is 20/50 visual acuity. So that is the eye that brought her in for the exam. And then 20/25 in unaffected eye. The diagnosis was clear. It's the new diagnosis of wet AMD in the right, with definitely intermediate dry age macular degeneration noted in the left eye. So, how would you approach this brand new patient here in your office, new diagnosis, meeting her for the very first time?
Yes, well, certainly, confirming the diagnosis on exam and with imaging, with OCT, and um, possibly fluorescein angiography as well. I would definitely recommend intravitreal anti-VEGF therapy. And in reality, a lot of us have to deal with the step therapy because of insurance limitations. And so I would start off with bevacizumab, off-label use in the affected eye, and then give at least 3 monthly injections to see a response. If there was still activity and by OCT, I would try to switch to an on label therapy. And I would try to switch to either aflibercept 8 milligrams or faricimab right away because I want to try to get the disease under control and extend as quickly as possible. What about you, Layla? How would you approach this patient?
Yeah, no, exactly the same. That would be what I would hope to. I think with the step therapy, like you mentioned, we are our hands set high to start with bevacizumab, and I will certainly start that therapy right at there on the first day after discussing all of the options with patient. But we know that insurance is going to tie this down to that option, and then after that, after injection, doing monthly injections for 3 times, try to extend to second generation therapy with the idea of really giving this patient the best um, chance of optimization, um, improving her visual acuity, but not necessarily seeing me as often as she potentially would on other therapies.
And do you always perform a fluorescein angiography on a newly diagnosed wet AMD patient, or do you think OCT is sufficient?
Yeah. I try to. I wish I could do it on all my patients, but sometimes depending on the location I'm seeing that patient on that day, my hands may be tied there as well. So I do find that OCT is extremely helpful. We've really described me, biomarkers and changes that we see and subtyping of IMD patients. I feel like OCT alone is helpful, and in this patient with this kind of story, it sounds very typical of wet AMD. If I see any signs of any other concerns, then we may be dealing with different pathology from wet AMD. I will definitely bring the patient back if I don't have fluorescein available on that visit for subsequent visits to do that.
Great. I agree with you completely. I think fluorescein angiography is, informative, but not absolutely necessary. It shouldn't stop you from starting treatment, which is the most important.
Yeah, wonderful. Well, let's switch gears to now a different patient. This is a 75-year-old male, Mr. Harper. He has been on aflibercept 2 milligram, treated every 2 months, so about 8-week interval. It could not be extended due to fluid recurrence. So really paying close attention on that OCT and seeing recurrence of the fluid. So considering switching to extended intervals, how do you approach this patient then?
Well, I think this is a great case of a patient who, has been on aflibercept 2 milligrams, which is a efficacious and safe medicine. But, coming back every 8 weeks is a burden to the patient and their caregivers. And we now have available in our clinics additional medicines that are FDA approved, either faricimab or aflibercept 8 milligrams, that have the potential of controlling the disease for longer periods of time. This would be a patient that I would try to extend by using one of these new medicines. I think if they're doing well on aflibercept 2 milligrams, I would advocate trying aflibercept 8 milligrams in this patient and then slowly extending. He was on every 8 weeks. I would go to every 10 weeks to see the response and then slowly extend by 2 week intervals. What about you, Layla? How would you approach this patient?
I feel like we practice very similarly in the sense that I agree with you. This patient clearly would benefit from longer duration therapy. I similarly would think about second generation. Given the fact this patient was on 2 milligram of aflibercept already, I think discussion and switch to how I would say it to the patient a little stronger, like medicine, but exactly the same medicine you're on right now. Would be an easy transition for that patient as well. And then I like to similarly extend by 2 weeks and bring that patient back on that interval and continue to extend.
Yes. And in the clinical trials of, aflibercept or faricimab, a lot of the extension was done at 4 week intervals. And so sometimes we're a little bit more conservative in clinical practice by extending by only 2 weeks. But I know some colleagues, you could theoretically try to extend, at longer intervals. But still, you have to maintain contact with the patient in case they have a drop in vision. You'd want them to come in and treat them right away.
I couldn't agree more. And just in one last question, when you do have patient, for example, on every 8 week interval, dry or in this case having fluid, at what point do you kind of think about, gosh, should we really give it a chance with longer duration therapies and give this patient a chance to be at 12, 16 week interval?
Yes, I think it's important to have this conversation with the patients because although we think, oh, they're doing great and they could come back every 8 weeks, you have to remember a lot of these studies say coming to the retina specialist, it's not just, the 1 or 2 hours they're in your office. It may be the whole day, be like a 6 hour visit for them, driving and recovering from the injection. So I think we underestimate the burden that it takes to come to the retina specialist so frequently. So I'm having these conversations with my patients more frequently and trying to tell them we have efficacious medicines that can be dosed less frequently. And many of them are very receptive to hearing about these new options.
Well, we're going to switch gear to our third case. This is a 80-year-old male, Mr. Jones. He could not come back regularly due to transportation issues. And I feel like, just like you mentioned, lots of our patients may not just have transportation issues, but having family members that are bringing them in, and that becomes challenging as well. It was started on bevacizumab about 6 months ago and was coming back about 1 to 2 month interval, but was really having difficulties with keeping up. In this type of case scenario for the patient, Dana, what do you do?
Yes, I think this is, a patient that we can commonly see in our clinic. It's very challenging for people to come back to the doctor's office so frequently. And this is a patient that I think would benefit from considering faricimab or aflibercept 8 milligrams. They were started on, off-label bevacizumab, probably because of step therapy. But now's the time to have that conversation, going right away to a medicine that potentially has longer duration and saying that, this would be the best choice for the patient because of the situation he's in. What about you, Layla?
Yeah, no, I agree with you. This is a very common case scenario. I mean, keeping up with monthly injections, not only from transportation reasons, but very much caregiver burnout is really true. And I think start getting those questions exactly 3, 4, 5, 6 months after you initiated a therapy. And we most certainly should be thinking about how to, optimize this patient, but really give them option of durability. And I think second generation anti-VEGF agents we have now in the market are really a great solution for this.
Yes, because if the patient, let's say they inadvertently, miss a visit because of other, social issues, at least if you're using faricimab or aflibercept 8 milligrams, you have a higher molar dose of the VEGF inhibitor. And perhaps that can help carry the patient and control the disease for a longer period of time, especially if they can't make it to the office.
So switching gears to our last case, this is also I feel like a common case scenario among our patients, especially in wet AMD and dry AMD area. This would be a monocular patient type of case scenario where we have been treating regularly and we do have great drying effect of visual acuity stability. And the question really becomes, at what point do you consider switching this patient to second generation therapies? What is the trigger? And why do it, so to speak?
Yes, I think we have many of these patients in our clinic where they've already lost one eye to wet AMD, and now their only seeing eye, of course, is very precious, and we want to be very conservative. And so these patients, I think they would, benefit from the data we've seen with either faricimab or aflibercept 8 milligrams. But yet we discussed we want to be very conservative. If I have this patient in my clinic, I'm extending them very slowly because this is their only good eye. So I would never extend more than 2-week intervals because I'm just, concerned that if something were to happen, this eye is what they're depending on. And I want to keep them, a close watch on their disease activity.
Yeah, I couldn't agree more. It's often the eye that they're driving with, reading with, functioning really all of their activities day to day. I'm very conservative in the sense that I want to have them on these longer duration therapies, these gray drying effect agents, but I'm a little hesitant to really jump a long duration and want to continue not only treating, but really following up to make sure I'm not missing something else as well.
Layla, there has been a debate in the past, like about, macular atrophy and intravitreal anti-VEGF agents. And, uh, there hasn't been any conclusive evidence that VEGF inhibition, contributes to macular atrophy. Um, do you think with these stronger second generation agents, is there anything we should be worried about because of their higher molar dose?
Yeah, no, I mean, those have always been brought up in great questions, most certainly. And I know some of the longer duration therapies that are on the market have really helped us understand that it's not really related to anti-VEGF treatment and frequency of it. It's really part of the pathology and disease of wet AMD that we do have macular atrophy down the road. I think future trials will help us answer this even more with some of the longer duration therapies that are in trials right now. But I very much take the approach of making sure this patient is not going to lose vision from wet AMD and treat them frequently.
I agree with you. I think the biggest barrier would be undertreatment and not giving enough VEGF inhibition. So that's the most important thing, making sure we control their disease.
Fantastic. So I think we're going to switch gears to a little practical discussion about switching, so to speak, in clinic. How do you introduce new therapies to your patients?
Yes, I think, if they're already receiving intravitreal anti-VEGF therapy with the first generation, I think the conversation naturally evolves because I want to tell them about an efficacious and safe medicine that can control their disease for longer periods of time. And so then I try to tell them right away, we do have these new FDA approved therapies, and many of them are interested because it will decrease the number of injections, the number of visits to the retina specialist. And many of them ask, what's the safety? Why should I switch? And I tell them that we've tested it in hundreds of patients and now, hundreds of thousands because of real world data. And so far, the safety has been excellent in these medicines. What about your conversation, Layla? Has there been any challenge to switching patients?
Yeah, no challenges when I discuss with the patients. I think they're all eager to come in less frequently to our office and receive fewer injections. So after having discussion of safety and ensuring that it's being now tested even real world, we have excellent evidence that these are safe agents. They are eager to minimize those treatment burdens as well.
I agree with you. Um, we also want to talk about, when we give these injections, how are you seeing in your practice the outcomes? Are you noticing actually that you're extending patients longer when you use faricimab or aflibercept 8 milligrams?
I love to kind of periodically just do reviews. So after we've started using these agents, we did kind of internal review of our outcomes and patient care and understanding what are the practice patterns we're seeing in our own practice. And we very much saw that we are able to extend these patients with these therapies, maybe not as long as what we saw in clinical trials, because we very much are still treating to completely dry out that retina and not see any fluid on OCT, but very much can extend it at least by 2 weeks in duration, which I think is a game changer when you're having to come in so frequently.
And a lot of the big data studies, like say the IRIS database, also looked at tens and thousands of patients with wet AMD who were switched to either faricimab or aflibercept 8 milligrams from their prior anti-VEGF agent, and it did show a lengthening of the interval between treatments of at least 2 weeks or greater. So it does show that there is extended durability with these new anti-VEGF agents.
Yeah, couldn't agree more.
This has been a wonderful and very educational discussion, Layla. I've always learned so much when I talk to you about patient cases, and I hope that this has been helpful to our listeners. And if they could just change one routine in their clinical practice tomorrow when they see a patient with neovascular AMD, what would you recommend it be, Layla?
Yeah. I think just asking ourselves, is this patient stable? But not just stable, is it truly optimizing the current therapies? So, with optimization, I think we need to strongly consider some of the newer therapies to give a patient chance to see us less frequently while we're keeping that visual acuity and that OCT stable.
Yes, I think that's a great question. We can always ask ourselves, we're in a busy clinical practice trying to take care of as many patients. And really, we have to think, are all our patients on the best medication possible today, given all the innovation that's happened? We need to move beyond our comfort zones and think, what would we want for ourselves if we were the patient? And we want to deliver the best care with the safest medication, allowing for the greatest durability possible. Thank you again, Layla, for joining me in this discussion. I'd like to thank everybody for listening today. This has been a great continuing medical education activity. Please continue on to answer the questions that follow to complete the evaluation. And I hope that you can join us for future educational events. Thanks again, Layla.
Thank you. It's been a pleasure discussing all of this with you.